So, are you ready? All right. So that's for CT scan. Are we done? Yeah. Okay. Moving on. Let's do MRI. Page 28.
Not in person, that's not video. We were getting an MRI and the kid had been shot like the metal ones, and they had like
All right. Let's begin. MRI. Listen up. So, an MRI of the scan of the head provides cross-sectional images of the cranial cavity. Contrast medium may be used to enhance the images. Unlike CT scans, MRI are obtained using magnets. Thus, the consequences with radiation are avoided. This makes this procedure safer for clients who are pregnant. The use of magnets precludes the ability to scan a client who has an artificial device like a pacemaker, surgical clips, or intravenous access port. Now, that's not entirely true in real life, just for your information. Certain devices are made to be able to still be able to scan them in MRIs. So oftentimes in real life, don't be shocked, right? If all they ask, MRI departments will just ask you to complete usually a questionnaire, like you do it with the client usually, or they will do it. And if they say, yes, I do have a pacemaker, they'll ask for the card that they carry for it, or do you know what kind you have? So based on that information, if not, you have to wait. Call the cardiologist, call somebody that knows what's inside. And based on the brand or the device, they determine whether it's MRI safe or not. Same with clips, screws, anything else. We need to know what kind they are. All right, now, but for the book, no devices. Now, MRI scans are used to detect abnormalities, responsive treatment, guide needles. Pre-procedure, remove any transdermal patches with a metal foiling. Transdermal patches with foil backing, as these can cause burn injuries. Ensure that metal objects, so no metal. This includes, but is not limited to, dentures, jewelry, belts, hair accessories, piercings. Make sure you ask them about everywhere. Piercings on their tongue, ears, nipples, genitals, toe rings. Make sure that they remove them.
What about tattoos?
Certain tattoos, especially permanent tattoos. Now it doesn't say it on here, I believe, but on certain tattoos. So women who sometimes get, yeah, these have contained metal within it. So it doesn't say it in the book, but in real life they do ask about certain eyeliners and eyebrow tattoos. They'll ask on them. So don't be too shocked. If sedation, so then hair accessory, everything's removed, okay? If sedation is expected, the client should refrain, so if they're gonna sedate them, MPO, 4 to 8 hours. You gotta ask if they have claustrophobia. Claustrophobia. Which means that they fear being in a small space. The MRI machine is like a small little tunnel that they get slid into. So they're very cramped in there, and it's like a very tight space. If they are claustrophobic, and we already know this, doctor will sedate them.
But that's only for
you know,
sedation.
like some Ativan or something to calm them down. Ask the client about any implants containing metals, such as pacemakers, orthopedic joints, which means joint replacements, right? Artificial heart valves. IUDs, intrauterine devices, aneurysm clips, ensure all people who get in the scanning area while the magnet is on, remove all jewelry, electronics, and phones to prevent damage to themselves and the magnet. Place pillows in the small of the client's back to prevent back pain from lying supine. The head must be secured to prevent unnecessary movement. Intra-procedure, tell them to remain still, and they can wear earplugs for intra-procedure. Now, post-procedure, same as the anything else, right? If contramedia is injected, make sure it clotted at the site. They're not having allergies, and stay with them if they're sedated until they're stable. Right? So post, check for reaction to the iodine, to the contrast media. Check for
Artificial
reaction.
heart valves, aneurysm clips.
What else did I say? And stay with them if sedated. Intra is they must remain still, and they can wear earplugs for the noise. It makes a lot of noise, the MRI machine.
What about open MRI?
What do you mean?
Like, is it, do we still have like, is the teaching still like stay still or is it different?
I'm not sure, but usually during MRI, they always should remain still. Yes? Good so far? A lot of these scans, the CT, MRI, I don't really review X-ray, it's pretty straightforward, right? Just ask if they're pregnant. They can't do it if they're pregnant. What else? Did we cover the EEG? All of these are just like how to prepare them. Like diagnostic procedures is always how to prepare them and what to assess, what to check. So hopefully with my little spiel of the last one, you can just apply it to this some more specific scenario. See, this is why I don't give long lunches. They're all dead.
What is the CV?
I should give you 5 minutes to eat a granola bar and still be hungry. But I tell you guys, 45 minutes, pasta.
Stay with them if
meals,
sedated.
and I don't know what.
Stay with them if sedated.
Yeah.
What does it mean, right there where it says stay and then see overscore? And that means sedated?
No, this is with.
Not, wait.
That means with.
Oh.
So stay with them if sedated.
Cause I usually see in the nurse's notes, and I've been doing it too, like the W slash.
Oh, yeah. I don't know. I know that's like general English, but this is with.
That's also sir.
Yeah, see with the light on. This is with, like with meals.
Oh, okay.
I don't know how.
I don't know how, I just know.
Do Yeah, it's a nursing abbreviation.
So not the W slash.
No.
Or W-O, yeah.
Yeah, it does. It's a 6-hour day. All right,
Management.
you ready? Next one. So, just so we, just so we don't say we didn't go over it.
So a pregnant woman can get an MRI, but she get it or not?
If they can, and again, it's just about risk outweighing that. The conscious is not so much the problem, I believe. I think it does cause placenta barriers, then again, it's like risk versus benefit, yeah. But generally, they are trying to avoid all scanning. A lot of what they perform is usually ultrasounds. No.
Yeah.
It would have to be like you're sincerely considering.
It'd be like dying.
They do allow for x-rays like that.
So, yeah, it just depends. Now, call me crazy, but I agree with the medical community.
Yeah.
Save the mom, man. And the
Oh, yeah.
that's, and that's always the answer on the test, by the way.
Save the mom.
I know,
Save the
I've
mom.
always say
This changes in real life if the fetus has more of a chance and the mom is gonna most likely die. But if there is a debate on one can be saved, they will just about always usually lean towards the mom. And I agree.
I have a little
Paano kung gusto ng nanay yun?
Ain't no one know that kid want to grow up.
You're gonna I don't know. I've never seen that situation in real life. But look. Hold on, real quick. I'll end your debate. You're speaking on emotion.
Let's see.
Save my baby. My baby. You know him. Oh, ladies, right? So, it's a personal choice. I'm sure in real life, a lot of consideration is thought of this, hence, talking with the doctors and whatnot. But for testing purposes, you generally and more than likely, if you read the question carefully, you will lean towards the mom. There are several factors for this. Speaking not with emotion about your baby. If you think about it, the baby cannot, especially when they're earlier on. I'm not talking about a 9-month that was about to be born in 3 days regardless. I'm talking about like a 6-month preemie. It's very difficult for them to live, in general, being out of utero. Yes, they can. Development is already not the best because you're out of utero so early. The likelihood of surviving is already down, especially from 6 months and prior, like under. So if you save the mom, you can have more kids. I know how that sounds, but it's the truth. And realistically, if you try to help the mom, the baby might make it. Does that make sense?
Yeah.
So, see what I mean? So if you look at it objectively,
But like also you don't know the kids.
another emotion.
No,
Yeah.
I know like logically like what you know like
So,
why
I'm just saying. That's why in testing, I think, and for safety, you lean towards the mom. Okay? Yes.
Can like baby daddy decide otherwise? Like
If
if they
you're
say
unconscious, yeah.
Like what if your wife got a really good
Unconscious. So let's answer the question realistically. Unconscious pregnant client, legally married, so next of kin, right, or power of attorney, or whatever you hire your advance directives. Obviously, that would trump the decision making because that's, you answer the question. It's like, well, if she's unconscious and unable to make a decision, whoever holds the next power of attorney legally or just by next of kin, would then decide. That's why you should have advance directives.
just make sure they do what
Because then if you don't, what if he's like, I've been eyeballing another baby mama. Hey, y'all might shrug right now. These are realities of the world. Okay? You don't want nobody. I told my mom, because my mom was like upset. My mom was upset. Like X-ray. Go to page 30. Real fast, we're just gonna read it over, there's not much to know. X-ray, page 30, top left. X-ray, page 30. We got this one and one more. Radiography, X-ray. An X-ray uses electromagnetic radiation to capture images, right? Black and white X-ray images of the skull and spine can be sometimes seen. Now look at pre-procedure more importantly. There is no specific pre-procedure for X-rays that do not use contrast. But a lot of the times they're the first tool to rule out a cervical or skull fracture or break, right? So the important bullet point is just determine whether the client is pregnant. Ensure the client's jewelry is removed, no clothes are over that area. The amount of the radiation used in contemporary X-rays is very small. Procedure is quick. No post-procedure care is required. So just determine if they're pregnant is a key thing. I see people miss it. Okay, or other people are always like, have you ever wondered why ER? When young females come in, first thing they do is pregnancy test to make sure that we're already, the first P you do, they want to test you, especially if it has anything to do like abdominal pain, head, like anything that points to like a complication or could be relevant to it. They're gonna ask you the pregnancy test just because they already like assume these tests may have to be run and we should determine if you're pregnant or not. Okay? Very straightforward. All right, last one. Lumbar puncture, starts on page 27. This is probably the most relevant to neuro. It's the most asked, most frequently asked. It can have its little variations or little interventions to catch you with. Lumbar puncture. Sorry, it can be lumbar puncture, which can be abbreviated as LP and is what you commonly know as a spinal tap. Okay? So let's read over it. A lumbar puncture is a procedure during which a small amount of cerebrospinal fluid is withdrawn from the spinal canal and then analyzed to determine its constituents. This can be done to detect the presence of some diseases like syphilis, meningitis, any infection or malignancy. It can also be used to reduce cerebrospinal fluid pressure, determine readings, instill contrast media for diagnostics, or administer medication or chemotherapy directly to the spinal fluid. Considerations. Pre-procedure, the risk versus benefits of a lumbar puncture should be discussed with the client prior. Now let's read this over. A lumbar puncture can be associated with rare but serious complications like brain herniation, especially when performed in the presence of increased intracranial pressure. So the brain can herniate if you have too much intracranial pressure. So you would have IICP, increased intracranial pressure. This is the pressure within your cranial cavity, in your head. Now, do you guys understand what a hernia is? You see brain herniation, you hear brain hernia. Everybody knows like a hernia happens down here when there's something heavy, like I got a hernia. But what is a hernia?
A protrusion.
Like bulging.
What's bulging?
Your brain.
The brain would be a part of the brain bulging.
So a hernia, right, in short, my whatever definition, is when you have different components or compartments within or how your body is structured. Now a hernia, let's say like, for example, right, you have like a little canal and there's like other organs somewhere else, but there's these openings. For example, your esophagus is one. Your stomach can herniate into your esophagus. What that means is, let's say, I'm gonna actually draw that one where it's like, right, and then you have your stomach right here, right? And it goes into your small intestine. This is your esophagus. Now, right here, you technically have a little sphincter. Things don't just magically stay in place, in case you didn't know, right? There's sphincters, which are like valves. So when you swallow, this quickly will open and close to let it go through, because the muscles are dragging it, and so it enters your stomach, it opens, but then it closes, so that this doesn't come back up. But should you do some sort of pressure, too much heartburn, the way you move, sedentary lifestyle, a lot of things, the stomach can herniate through that pyloric sphincter. So then here, what's gonna happen is the stomach is gonna force itself out, and then it's bulging here, like this, right? Like the stomach is now like bulging through, it's coming up into your esophagus. So it went out of its place through another opening. Now in the case of your brain, right, and then it goes into the brain stem, right? The brain is trying to, or has, forced itself down into the spinal canal. Like your brain is being pushed in. Now this is happening because what? Well, you have your skull, and as the pressure expands, it has nowhere to go. But the spinal canal is open to it. So then it'll slowly start to squeeze into the spinal canal. This is obviously extremely dangerous because your brain tissue is not meant to be, right, so squished or being forced down like that. So that's a brain herniation. It's going into your spinal canal, out of its own cavity into the next canal. So if you're having all this pressure here, okay, so you have all this pressure, and then we poke, right? You break through the spinal canal down here. Well, now
There's another opening.
we have a release of the pressure, so everything's gonna want to find where it has room. You're relieving the pressure here, you're doing all this, so everything's gonna try to force its way down, because there's a relief. Yes?
Could it actually like squeeze its way through like that? You know,
Tell you what?
like the vein would like try going towards that area and like squeeze.
If it's small enough, like yours, it'll. No,
Ooh, shots fired.
I'm just kidding. Not the whole brain, obviously, but like
A part, like you know.
your cerebellum and your brainstem are the first there. So it's obviously the back end. It's trying to, and I'm not saying like it's gonna.
Yeah,
fit
no, it's
into
not
your-
gonna like squeeze its way down, but like
squeeze
the
it,
part.
but the fact that part of it is leaning out to it, it just compromises circulation. Right, like it's horrible. It's really horrible. So what are ways to do this? One, remove part of the skull. Allow it to expand, right? You can do things like that. There's different solutions to try to get it.
Isn't that even diuretics, so like they pee out the urine,
They
pee it
can
out?
try to get fluid out, depends on what's causing it. So, they do burr holes, right? A little hole just to allow pressure to release. So it depends, but you wanna get the pressure out. Okay? So, the point that I'm trying to make here though is, if too much ICP, if there's too much increase in, so if you know the patient has increase in intracranial pressure, you cannot, or should not, I should say, you should not perform a spinal tap. It's a contraindication. Lumbar punctures for clients who have bleeding disorders or are taking anticoagulants can result in bleeding that compresses the spinal cord. So they're at risk for bleeding. It can potentially be a contraindication. Yeah. Nursing actions. So what do we do? Pre-procedure. Now that we know the contraindications, what do we do? Look at page 28, top of it. Nursing actions, page 28. Ensure that all the client's jewelry is removed. The client is wearing only a hospital gown. Instruct the client to void prior to the procedure. Obtain vital signs and perform a baseline neuro check of the client's legs. Because if they mess something up, right? Baseline neuro check. Make sure that their neural function is intact or where they're at currently. And then client should be positioned to stretch the spinal canal. This can be done by having the client assume a cannonball or fetal position on one side, or by having the client stretch over the overbed table if sitting is preferred. So you can see pictures on your book, right, of that position. So they're basically gonna do this to expose their spine. It can be on their side, right, they're lying down, or if they prefer to be sitting, you can sit and lean over the table so that their spine is stretched out. Entry procedure, ensure that sterility is maintained. This is aseptic technique. Now remember, you're not doing this, a doctor is. The area of the needle insertion is cleansed and a local anesthetic is injected. The needle is then inserted and CSF is withdrawn. A manometer can be used to determine the opening pressure, which is useful. Increased pressure is a consideration. Post-procedure. The pathology is sent to the department for analysis. Monitor the puncture site. The client should remain monitor puncture. The client should remain lying for several hours. To ensure that the site clots and to decrease the risk of post-lumbar puncture headache caused by CSF leakage. So you remain lying to prevent bleeding, leakage, and the headache from the shift of fluid. Okay, obtain the vitals, perform neuro check of the legs. Can you feel, can you move this, can you push? Right, normal activities may be resumed after the prescribed bed rest. Complication. If clotting does not occur to seal the dura puncture site, CSF can leak, resulting in a headache and increasing the potential for infection. Encourage the client to lie flat in bed and provide fluids for hydration, administer medication. So lie flat, increase fluids, report headache. 3 of the key points. Make sure they intake fluids. Monitor the site for a hematoma formation. Hematoma, they're bleeding, right? Like not outwardly, like the blood might not be coming out of their skin, right? But even inside, it could be bleeding internally, like here. You see it pulling under the skin because it still is bleeding, just not bleeding outwardly.
You gotta come stand here, like right here gets freezing.
Is there anemic?
I am. I am.
Make sure that it's just a sterile environment is maintained. They don't really ever ask about it. Just help them stay in the position and make sure that they're sterile. Yes? We good with diagnostics? X-ray, MRI, CT, EEG, and spinal tap. Yes? Good?
Mr. Romano, I have a question. If one of the questions state a client has this type of, is suspected to have this type of disorder, what type of screening or what type of, what do you call this? Diagnostic screening will they use? Would that be one of the questions?
Potentially. So, I'll phrase it to you better. I know what you're asking. And I don't know if I have questions like that, but how I usually see it asked is they kind of already describe what's wrong with them. So they ask, what do you prepare for, or what should you, or what do you, it says what diagnostic or what action does the nurse anticipate? So it could say like, you know, the patient comes in, reports, you know, sensitivity to light, has a fever, and is now confused in the last 2 hours. the nurse should anticipate
9.911.
and, right, which of the following diagnostic procedures. So you then, though, based on what is heard, the patient have to assume what the disease is, or in some cases, they'll tell you. So they'll say like, the patient is sensitive to light, has had a fever, and has now been confused for the last 2-3 hours, and meningitis is suspected. So then you do have to know how are you gonna diagnose it?
Okay.
So in short, you should know what belongs to it. But right now, you know how we did all these, we did all of these? There's so many diseases that you'll do that for. So I would reverse it. You should know, like, don't think like, MRIs could be done for a number of things. So it's hard to remember all. But when you're actually going over meningitis, we will go over what are the steps. So the first one is when they do seem to be having meningitis, you isolate them and the spinal tap will confirm. So you will have to follow a process and that will be asked, but it's more specific to the disorder, not to the exam. I don't know if that makes sense.
Got it, yeah.